not because they've been singled out as being an okay. It's about trying to target conversation.
Hello everybody. Sorry, I'll take my glasses off so I can see everybody. And welcome everybody to the Health and Wellbeing Board meeting. It's 20th of July 2023. I'm Leslie Deadman. I'm the chairman of BCP Council, and I'm here in order to help elect the chairman for this particular board. So I'm going to start the agenda with apologies. Louise, have we any?
Sorry, can I just read the housekeeping?
Oh yes, I'm so sorry. I'm bursting forward.
Please note that this meeting of the Health and Wellbeing Board is being recorded by the Council for live broadcast and will be published on the Council website for a minimum of 6 months. The meeting may also be recorded or streamed for live or subsequent broadcast by members of the public, although ultimate discretion in this matter lies with the chairman. For those in the room, please note that if a fire alarm sounds, please exit the building by way of the nearest available signed fire exit route and make your way to the War Memorial in the lower gardens. And finally, please ensure background noise is kept to a minimum and mobile phones and other devices are switched off or turned to silent for the duration of the meeting. Thank you.
Thank you. Now we'll burst into the meeting. So sorry about that. Item 1, apologies. I'll have you in.
Apologies have been received from Patricia Miller, Karen Loftus, Graham Farrant and Mark House.
And do we have substitute members?
Yes, we do. David Freeman is substituting for Patricia Miller. Emma Lee is substituting for Karen Loftus. Darren Langdon is substituting for Mark House.
Thank you. So,
Richard Renault is substituting for Siobhan Harrington.
Oh, hello, Richard. I didn't realise you were substituting. Nice to see you again. Right, substitute members. We've done election of the chair of the BCP Health and Wellbeing Board. Now, I'm looking around the table for nominations. Do we have a nomination for the chairmanship? Yes, thank you, Richard.
Thank you, Chair. I'd like to nominate Councillor David Brown.
Thank you. And do you have a seconder? Can I second? Oh, yes. Yes, okay, that's fine. Do we have any more nominations? I think we've given that enough time. Right, thank you. In that case, I can declare that David Brown will be taking the seat as the chair. I'm going to leave the meeting now and hand over to you, David. So give me a second to gather my things. Right. Okay.
Thank you.
Right. Thank you very much.
Thank you.
Thank you. Thanks.
In the hot seat.
Right, thank you all for that. The next agenda item following my election as chair, and it's a sort of new committee for me, so I shall endeavour to do my best as the chair of this committee, but I'm sure I'll learn as we go along. Item 4 is the election of the vice chair of BCP Health and Wellbeing Board. There was a proposed vice chair, but as they've sent apologies and have a substitute, we'll need to defer this item to the next meeting of the Health and Wellbeing Board, if that's okay with everybody. Okay, nodding heads all around. Good. Okay, we'll do that. We'll defer that to the next meeting. Following that point, as I'm the new chair, and we've got a number of substitutes here, I would just slightly depart from the agenda, just like to go around, just get introductions. So I'm Councillor David Brown, the new portfolio holder for Health and Wellbeing on BCP Council.
I'm Louise, Democratic and Overview and Scrutiny Support Officer.
I'm Sydney, I'm here for work experience, so
Pretend I'm not here.
My name is Neil Bacon. I'm the Chief Strategy and Transformation Officer for NHS Dorset. I'm here to share with the group the 5-year forward plan later.
And I'm Sam Crowe. I'm the Director of Public Health for BCP Council and also Dorset Council.
Hello everyone, I'm Richard Renault. I'm substituting for Siobhan, who gives her apologies from University Hospitals Dorset.
David Freeman, Deputy Chief Exec and Chief Commissioning Officer for NHS Dorset ICB. And Chair, I need to leave the meeting about 2:20 because we need to get across to University Hospitals Dorset for a meeting there, and particularly on this day of the consultant strike and all the rest of it. It's an unfortunate clash in priority, so apologies.
Okay, thank you.
I'm Betty Butland, Director of Adult Social Care, BCP Clients. Councillor Richard Burton. I'm the lead member for Children's and Families.
Afternoon, everyone. Phil Hornsby. I'm interim corporate director for Wellbeing for BCP Council.
Jess Gibbons, Chief Operations Officer for BCP Council.
Thank you very much. That's all.
On the screen.
As you're here. And there's people on the
yes,
screen,
yeah.
of course.
Yeah, should get the. I'll go through who's on the screen as well. We'll start with Councillor Kieran Wilson.
Hi, thank you. Yeah, Councillor Kieran Wilson, Cabinet Member for Housing and Regulatory Services. And yeah, apologies that I can't be with you in the room. But yeah, thank you.
Louise.
Hi, I'm Louise Bate. I'm the manager at Healthwatch Dorset. It's nice to see you all. Sorry I couldn't be there.
And Emma Lee.
Hi everyone, hi, I'm Emma Lee and I'm the Partnerships Manager at Community Action Network and I'm here as a substitute for Karen Loftus.
Thank you, Emma. And Rachel, if you could just introduce yourself.
Hello, good afternoon. I'm Rachel Partridge. I'm Deputy Director of Public Health at Public Health Dorset. Sorry I can't be there. I have a meeting at 2, but I thought I'd pop in and see the first half an hour. Can't stay away.
Thanks, Rachel. Got a few guests as well. Just ask. Just introduce yourself.
Hi, I'm Lucy Mears. I'm Communications Manager for Public Health Dorset.
Sarah Longdon, Head of Service Planning at Public Health Dorset.
And I'm Cecilia Bufton. I'm the ICP Chair.
Right, welcome everybody. Thanks for that. And just to clarify, if there's any papers we come to actually voting on, it's only those members of the Health and Wellbeing Board that are in the room that are eligible to vote. So unfortunately, those who are attending online can't vote on any items. So just to clarify that. Next, item 5, confirmation of the minutes. So just unless anybody indicates otherwise, this, to assume that the committee agrees to confirm the minutes of the meeting held on the 23rd of February 2023 as an accurate record. I wasn't there, so I'd have to rely on those that were there. So,
Yes.
Okay. Getting some nodding heads. So, the committee agreed that those were an accurate record. Thank you for that. Agenda item 6, declarations of interest. If any committee members have any declarations of interest, if they can indicate either raising a hand online or indicating in the room. Any declaration of interest? No? Okay. None to record. Item 7, public issues. Louise, are there any public issues for this meeting?
There are no public issues.
No public issues. Excellent. So we can move on to the next item. Because I know some members in the room can't be here for the whole meeting, decided to just slightly adjust the order of this meeting. So we're going to move agenda item 10 to be the first substantive item of the meeting. That's the Better Care Fund 2023 to 25, because that obviously needs consideration and needs us to vote on it. So if that's okay, we'll go to agenda item 10 first up, and then we'll come back. So Better Care Fund 2023 to 2025. Phil, you were going to present that for us.
Thank you, Chair. So for members who haven't been part of this board previously, I will do a little potted history of the Better Care Fund, but this report is to set out the new Better Care Fund plan that we had to submit in June, and normally it would get signed off by the Health and Wellbeing Board before submission to the central government, but because of the timings of the meetings, we had to submit on the understanding that this board would give its final approval. It has been through other sign-offs, so the Chief Executive of the Council, the Chief Executive of NHS Dorset have both seen and signed off their support for it. So it isn't just a rubber stamp though, this is for the board to really consider whether they feel this is appropriate. To caveat that, I do want to say that we've already, when we submitted it on the 26th or the 28th of June, I can't remember the exact date, we've already had confirmation back that the plan has been assured and it meets and is compliant with all the requirements. So we have no further work to do. Not trying to persuade you in any way, shape or form about what you might want to decide at the end of the report. So this is the covering report is really just an overview with some headlines from the report. The plan itself, the plan has three elements. There's a narrative, there's a detailed account of the schemes, of what we will be doing, how we will do it, and then the metrics and the performance, what we expect to achieve and in what timeframes. So those are the appendices to the report. So I'll just quickly go through the Better Care Fund has been around since 2013. It was and continues to be the approach to how health and social care across the area come together in an integrated way to deliver services that meet the benefits of our residents. Quite a bit of focus around hospital discharge and supporting the broader health of the population. But it is a pool budget. It brings together funding that the council contributes, that NHS Dorset contributes, and that includes a minimum contribution that NHS Dorset have to provide as dictated by government. But it also includes things that members might not be aware of, such as the Disabled Facilities Grant. So those adaptations to people's homes that will enable them to live independently comes as part of the Better Care Fund, but we devolve that responsibility to our housing colleagues who operate the grant scheme and ensure those adaptations take place, hand in glove with adult social care who provide the occupational therapy elements. So this is a 2-year plan, which is a move away. They've usually been annual plans. The one issue we have is that some of the funding that is included with this is short-term funding, national funding, but is ring-fenced to be part of the Better Care Fund. We will need to see if that funding continues into year 2. If it doesn't, then we will have to review the plan and say what changes may we need to make. So just want the members to be aware of that. So the main parts of it are the narrative plan and the planning templates. The narrative plan does set out how we're going to work and what we're going to do. And it builds on work that's been going on for a number of years. The schemes themselves haven't particularly changed, but we have agreed that we would like to fundamentally review the Better Care Fund plan and approach. What we do have are a lot of services that are integral to the way we operate at the moment built into the funding. And so we may need to review what is our overall approach and then the detailed approach that makes it even more integrated than it is at the moment. It's an alignment and pooling of funding. What hasn't necessarily happened is the alignment and pooling of resources into integrated ways of working, which is really the next iteration, and will link into the work when we talk about the forward plan and the ICS work as well. So there are connections right across these things. It's developed in partnership with NHS Dorset. It's not the council doing this on its own, and we do engage with a number of stakeholders, providers, people who use services in developing the plan and testing out that it is doing what we want it to do. So it has to be jointly agreed. It has to implement Better Care Fund policy, and there are a number of objectives in that, including enabling people to stay safe, well, and independent at home for longer. That's where equipment and adaptations come into play. Providing the right care in the right place at the right time. That includes how we discharge people from hospital in a timely way or prevent them going in hospital. And we have a set of schemes which are linked to 5 key areas: maintaining independence, early supported hospital discharge, integrated health and social care locality teams, carer support, and moving on from hospital living, which are people who formerly lived on hospital campuses, so within hospital grounds, NHS trust operated facilities with a long-term learning disability. And there's been a programme in operation since about 2010 to move them on from that accommodation into the community. And this is just the pooling of the funding that goes towards supporting those people in the community. Financial implications: there is risk built, for both organisations, both NHS Dorset and the council in this, because we need to deliver what we've set out to do. The government does test us and challenge us and ask us to understand how we're delivering. and it'll be part of this board's role to receive reports during the year and at the end of the year around the performance of the Better Care funding, whether we're meeting our objectives. There's real detail in Appendix 2 around each of the schemes, but there's a summary table in here that shows how we deploy the money, which in total is a little over £71 million, so a not inconsequential amount, split over several schemes, and you can see how the two contributions from there's a typo in here because it says CCG, so it should say NHS Dorset, so apologies for that, and then the council's contribution. And as you can see, NHS Dorset make significantly more of a contribution, a lot of which is linked to the minimum contribution, but also the integrated health and social care locality teams, which includes a fairly substantial amount of community nursing capacity and resource. The thing that we have to have in place is what's called a Section 75 agreement, which is was in accordance with the 2006 National Health Service Act, and it's a way that we pool. It's a way of pooling budgets. It's the legal form that brings that together, and we already have one for the previous year. We need to refresh that to include, and that needs to be signed off by both the council and NHS Dorset. And that is a legally binding contract in effect that we will jointly work to deliver, and it requires a pooled fund manager and normally someone from the council who will oversee that and report on progress. It's key delivery vehicle for our person-centred approach to care, and particularly around those people who need support out of hospital. And I just would, rather than going in any further detail, if it's okay, I'll open it up to questions from the board.
Okay. Any questions from either those in the room or those online? Jess.
Thanks. I just had a really great morning actually out with our maintenance teams who do the work to do the installation around the Disabled Facilities Grant. And today I've seen kitchens that are being lowered, I've seen bathrooms being readapted, bedrooms being adapted for disabled children, those sorts of things. Really, it's amazing. It's absolutely brilliant work that they're doing. But one of the things that was coming up was people are waiting sort of 2 years to be able to get their homes adapted. And in that time, there's significant degradation in their life and in their impact. And I'm just wondering, you know, this is all great, but how is this seeing us drive some improvements in those areas, which is really in, think about all the conversations we've had around the integrated care system, really in that prevention and early intervention space. And I think that will sort of open my eyes to that impact on people's lives when we're not being able to implement those improvements. So the system can deliver it, we're just not delivering it in a timely manner for people.
Thank you, Chair. I had a sort of supplementary to that, I think, Jess. When I was reading through this, I do this every year. I read the Better Care Fund report. It's highly shaped by the national requirements and the template, and it's written in a particular way. I guess my question was, what would be possible when we're thinking about the metrics? Because I know we've got some national metrics that we have to report on. But in paragraph 13, I was quite struck by the phrase, the BCF is a key delivery vehicle in providing person-centred integrated care with health, social care, housing and other public services, which is fundamental to having a strong and sustainable health and care system. So how would we start to think about measuring that, given Jess's really good example? And if I make the link to the forward plan that we're going to talk about later on in the meeting, there is a commitment to increasing the number of older adults who would say that they feel they're living well and they feel supported. And at the moment, we measure lots of things that systems tell us to collect, but I'm not sure we're asking necessarily the right questions about what their quality of life or their experience has been, or how well they feel involved in decision making. Did we act quickly? If we could start to think about some of those metrics to bring the plan to life, I think that'd be brilliant.
Should I start? I'm going to be really cheeky just and ask you to answer your own question. So in terms of how quickly we get a grant.
So it takes 2 years for the grant to get through.
Which is within our housing department. department.
Yeah.
So how, and that, what are there some efficiencies in that? I think there's a link into Betty's area around
OT.
how quickly we get the OT, the occupational therapy assessments, to
Yeah, so that, yeah,
say
that's a bit
how
less concern.
what does the adaptation need to look like that best meets the needs of the individual. So I think it's a really good challenge, but I think it's a challenge for us to council as a whole, isn't it, to go, what can we do that would streamline that time delay, which is way too long, to get that adaptation done, because in that time someone may have needed to have a hospital admission because they've fallen, or they've not been able to move, their mobility's been restricted because they can't access the upstairs or the bathroom, or so that I think we should challenge ourselves and say jointly, what can we do to review that process, and is there any way we can take other things in there that we can take?
I think the concern for me is we take this report and nobody's mentioning it. That's where my concern lies, and I'm not being critical of anyone's team, just saying I wasn't even aware until I went out this morning and met people, met families, and they're saying 2 years, 2 years consistently. But it's that sort of thing, isn't it?
And there are components.
Which comes back to your data point.
Some of the, and I'll come on to Sam's point, which I think is really important. I think some, if it's a simple adaptation, sometimes it's quicker, but where it requires planning and changes to the use of the property, or an extension, say a disabled child, that's where that time frame. But if it's a simple adaptation for a level access showering, it shouldn't take anything like that. It should be weeks rather than months or years. So I think that maybe that's an action point for us to take away and go, how do we challenge our teams to streamline that process? On the metrics, Sam, I think it's a really good point, and there's an item further on in the agenda around the CQC assurance process, where one of the things that we'll be challenged on is what is the journey that the person has, and how would they tell you, how would they reflect back to you what it was like for them? Was it a good experience? And Louise from Health Watch can give examples of where people have expressed poor experiences in the past. How can we, and one of the things that we'll be considering is, can we use an appreciative inquiry approach that really takes people on that journey in a narrative way to understand the quality of their journey, right from the point where they maybe approach their GP and then get into the system one way or another, and hopefully get a good outcome and come out the other end of the system with the right support and say that was a good experience. And if it wasn't, what do we learn and what do we change? So I think we need to do some work, not just about the numbers, but about what was the outcome like for the person. So I think that's some work for this board and beyond.
Betty was next. Betty was definitely first.
Thanks, Richard. Yeah, so just picking up on what Phil and Jess have said, I think there is real potential to really look at scrutinising what we have in particular in the 6 key areas, the schemes and the descriptions of the 6 key areas. I think looking at maintaining independence, for instance, really fits well into what Jess has just said. That in itself, if you looked at breaking that down, maybe each of those 6 areas, and then putting some tangible matrices and feedback from each of those, because just the example around somebody having a DFG and then having their adaptations and how long that can take with architects, with OTs, with lots of other people, with families, etc. I think for me, this is a real opportunity to look at how we're delivering against the 6 key areas. There's a lot of discussions going on around how we're doing things in a true integrated way. And I think now is the time to really look at that, scrutinise that. I think just touching on what Phil said, it's really important that maybe we think about capturing people's stories. We want people to tell us their story and their journey. We want to co-produce more. We want people with lived experience, particularly when you look at this about the individuals. And I'm kind of looking at Louise with some of the stuff that Health Watch have done around getting feedback from those with lived experience, but particularly also around carers. We know we have a high number of unpaid carers that support us within the Dorset area and the BCP area, and I think there's a time now for those people and for each of these areas to start telling those stories, and maybe looking at an appreciative inquiry maybe around one of those areas might be something that is the way forward. I know we're certainly looking at it that nationally and within the region, Southwest region, within the ADAS group, because we talked about it only this week. So that might bring some potential as well. Thank you.
Okay, thanks for that, Betty.
I think actually Louise was as well.
Louise from Healthwatch, do you want to?
Thank you. Yeah, just to build on what Phil and Betty were saying, really, it seems like there's a real opportunity here to speak to people at the beginning of the journey and perhaps recruit a couple of people who'd be happy to keep a diary of the process so that you've got that entire story of what it's like from a few people going through it, which I think would really help with some learning. I'd be happy to talk to you about how to go about that.
Thank you.
Okay, thanks for that, Louise. Richard.
Thank you, thanks. Yeah, fully support this, and I think it's a really good piece of work. In terms of just looking at the difference it makes for £70 million investment, I thought that the indicators are on. I'm going to go slightly on the qualitative, which I completely support, but looking at some of the impact that we're trying to make, it's just really to perhaps explore a bit about how the data is presented. So we're getting technical, statistical process control. Are we making a difference? Is it meaningful? Is it sustainable? There's some ways of doing that I think might be useful for this board to consider, particularly over time. But where the two I was going to pick out was linking to Neil's presentation later. We know that falls is a big issue, and we've made good progress 2 years ago to last year, but the target set as flat for this year. We've got ambition there to try and reduce falls. But the one that, and I might be misreading this, so apologies, but on the reablement, that looked like a drop, is that right? So the 8.5 on page 154, I think. But just seeing about, so that's portion of over 65s still at home 91 days after their discharge from hospital, felt like an area that, again, if we're linking to the strategy we're going to be discussing next about quality of life and supporting independence, that felt like I might be misreading this bit. Are we going backwards on that? So, or is that, have I misread it? Is it the other way around?
It's something to do with the way that we're now having to measure it.
Yeah.
Right.
So
okay.
We've changed the measure slightly.
Right.
Sorry.
Okay. No, it's fine. Just 95 sounding brilliant. 71.
Yeah,
that's good.
Yeah, and it's in two parts. So there's it's reablement and rehab, and so it's rehabilitation. And it's how we capture some of the data and the information from partners. So Dorset Healthcare play a big role in this, of course. The hospitals themselves play a role, and social care has a role along with our providers. So I think there's again something about how we capture data and then present it. So I think it'd be interesting for us collectively to try and nail that once and for all, because we've been trying to do it for some time.
Right. I just think I know we're doing the agenda in the order, but aligning this to our long-term ambitions would be helpful. Yeah.
It's interesting. Sorry, Chair, for a minute. It's interesting, the agenda actually. There's some strong links right through all of the items that interplay, and we need to not lose sight of that. And I know Dorset Fire, we've got there's a role also that you play in some of this work around the prevention work that you do with people in their own homes. So, and I don't think we capture that very well in this narrative either. I think there's more that we can do.
Okay, thanks. So, any other questions or points? That was, for me, it's a very informative discussion actually, and I'll probably pick up a couple of points in a moment. Any other?
Just, it's not specific, it's more general. So clearly Dorset, NHS Dorset fully support this, sort of contributed into it. This is, I'm just building on something that Phil said in his introduction. This is a 2-year plan. Normally it's an annual plan, so you don't have much scope to change very much, because there's a lot of it is, as Sam alluded to, the a lot of it's dictated to us. In this 2-year cycle that we've now been given, we have a real opportunity to sort of reflect and grow and mature that as we come out of year 1 plan, which is where we can be more certain about what we need to attend to. We can be much more creative and expansive going into year 2, which ties brilliantly to some of the other opportunities that we've got. It's already been talked about, and we have more flexibility in doing that. So that was one thing to note. The other thing I wanted to flag was that it's not on this agenda, but in upcoming discussions at this point, we'll be talking about the opportunities we've got around place-based partnerships, around working differently with our neighbourhoods and localities across the BCP footprint, and the requirement that brings, but also the opportunity it brings to pool more effort, more budget, more resources. And we will be looking to use the BCF and the Section 75 mechanism to do that. So it's more to say that the way this has been established creates that opportunity for us to do it when we get to those points in time. So more to signal to the board that this is a good piece of work, because it's not easy to do this sort of stuff, and especially as they changed the deadline for doing it as well. It's meant to be September, which is because it was a 2-year plan, but they moved it to June. So it's been designed in that way to help us have that flexibility, which also brings in the opportunity for us to sort of really zoom in on some of the critical points that colleagues have raised here, as well as part of that iteration and evolution. But I'll just kind of plant the seeds that this will be a kind of anchor point for some of the work we want to do in our kind of real transformation and improvement of health and wellbeing across the BCP footprint. So just to signal that, but I think it's a really exciting opportunity.
Okay. Thanks for that, David. That's useful. Any other comments on that? Mr. Race. Just for me, actually, that was a really useful discussion. Actually, I just wanted to try and pin down, because obviously we've got a recommendation on this item, just the board to approve it. Sort of, from what's been said, it's a sort of retrospective approval, but it's nice to know then that actually we've already had the feedback that it's been accepted. And you know, when I've looked through the report, there's a lot to it. There's a lot in there. I don't want to sort of lose what we've had in the discussion, just for partly for me, but then for us as a board, how we make sure that we capture that and we actually do look at the points that Sam's raised about other metrics to make sure that it is delivering what we need it to, and the points Betty raised about those sort of key areas, and also working with Louise at Healthwatch to progress that. Do we need any additional recommendation for this board, or is that is it sort of integral within there? I don't know.
So I wonder, Chair, if we just pick it up through the actions and then make sure that we monitor the actions.
Okay.
And if I can suggest that not for the next board, but the one after that, make sure that we bring a mid-year report on how we progressed, and then we are required to do an end-of-year report. Well, this is predicated on the availability of the data, but I think we should get into that rhythm and approach that says we will come back, because it does link in with the other things that we're going to talk about later, so we shouldn't just leave it for a year.
Yeah. Just to check on that, then, do we have the officer time and resource to be able to sort of do that and do the sort of monitoring and do that work to come back mid-year?
So one of the things we did this year, which we haven't had in the past, is to align some of the resources from the Better Care Fund to a Better Care Fund manager or an officer in the council to spend more dedicated time on this, because it's kind of been as part of someone's job and doing everything else, and that's why I don't think it's necessarily had the focus it always needed. And because of the responsibility as the pooled fund manager, there is some reporting that needs to go back through NHS Dorset as well as ourselves. So I think we can use this board as that point of reference and check and balance, and then whatever report from here, I would, and Dave, I'm just looking here, without having rehearsed this with you, that report could then go to NHS Dorset as part of the validation. So I think if we get into that structure of approach, that business cycle, then we can meet the requirements and be challenged by the board if we're not doing what we need to do.
Okay. Is everybody content with that that's been said, that there'll obviously be actions within the minutes, and so we have a mid-year report. I'm not sure, I have to look at the schedule, so in 2 meetings times.
Yeah.
Everybody happy with that? Thanks for that. I don't have any other questions. That was I think that's a useful discussion, useful for me, and actually as an introduction to the Better Care Fund. If you could just pass on thanks to those who've been involved in actually putting that together, because I appreciate that's quite a big bit of work, and as I said, the sort of timetable was changed, so I'm sure that sort of created its own difficulties in terms of delivering that. So we've got a recommendation for the board that the Health and Wellbeing Board approve the Better Care Fund plan for 23-25, taking into account the investment and delivery plans as outlined in this report. I think as it's a sort of formal recommendation, if I could just ask for a show of hands of those in the room if we're in support of that recommendation. That unanimous, is it? I think that's unanimous. Thank you for that. That's great. Okay, so that was agenda item 10. We'll now move back to the previous structure of the agenda. So we'll go back to agenda item 8, if that's okay. The joint forward plan for 2023 to 28, making Dorset the healthiest place to live. Neil, this is an item for you to present.
Thank you. Thank you, board, and thank you for making the space on the agenda for this. And thank you for looking at it already. I look forward to comments, challenges and improvements. So I suppose the sort of top line figure is that the 5-year forward plan developed by NHS Dorset, the ICB, is essentially, big aim is to make Dorset the healthiest place to live. And I think it's good to keep coming back to that and remembering that. And it was developed, as many of you are aware, developed sort of as a response to the ICP strategy, which itself was built on a lot of engagement with people, the joint strategic needs assessment, detailed understanding of the challenges that we face, and indeed the opportunities to improve the health and well-being of our communities. A lot of data was involved, of course, both in the ICP strategy and then in the development of the 5-year forward plan, in understanding the discrepancies and the variation in life expectancy, morbidities across the different areas of Dorset. As you see, the plan was developed over what we call the 5 pillars. And it's really interesting, of course, as soon as you develop 5 pillars, you meet all the people who say that what they wanted wasn't in it. Of course, this doesn't exclude lots of other pieces of work, but the aim is to provide real focus across the ICB and NHS Dorset on how predominantly health can support and deliver the ICP strategy. In Dorset, we developed it in a way that only a few other of the integrated care boards did, and saying, well, although our responsibility and our remit is what is health's contribution, we try to take a much more holistic view and say what can health do together with partners to deliver it, rather than making it isolated. Because as you'll appreciate very well, this board will appreciate very well, if we're going to make Dorset the healthiest place to live, we're not going to solve that through or make that happen through interventions of only the health part and the NHS part of the system. So what communities told us was really important, what colleagues working in health and care and other parts of the system, local authorities, the voluntary sector, Health Watch was critically important. And also, when we looked at it, we said, what will happen if we do nothing? So when I come on to the 5 pillars that we placed, so what would happen if we did nothing, or more to the point, if we carried on doing what we're doing? What would happen to the proportion of children who are overweight? What would happen to admissions and the lives of our older population? What would happen to the mental health of people in Dorset if we did nothing, or if we carried on doing what we're doing? Because it sort of creates hopefully a clear and compelling case for why the plan and what's been proposed will make a difference, will really change the shapes of some of these curves. So the 5 pillars are to improve the lives of 100,000 people living with mental health problems, and of course the computer's decided to shut down there. To prevent 55,000 children from being overweight, and in brackets says 2040, and I'll come back to you're thinking, well, a 5-year plan, 2040 is longer than 5 years, so I'll preempt that. But as I say, prevent 55,000 children from being overweight, brackets 2040. Reduce the gap in life expectancy between our most deprived and least deprived areas from 19 to 15 years, and we think that by 2043. To increase the percentage of older people living well and independently across Dorset. You'll appreciate the percentage doesn't yet have a figure, but that, and I'll come back and, if I may, talk a little bit more how that relates to the preceding topic that we're talking about. Just specifically, the metrics in there will be a basket of metrics because there isn't one individual one that works, including falls, strokes, fractures. So you can see how, and as you've pointed out, there's a thread running through this agenda that we're seeing. And then the final one is to add 100,000 healthy life years to the people of Dorset by 2033. We've tried, well, we have made and it comes again back to the conversation we're having about making the objectives specific and measurable, achievable, realistic, and with dates. Many of our sort of other ICBs across the country, their plans say things more like, we will give every child the best start in life, or we will ensure the best for our older population. We wanted to move perhaps slightly beyond that to put specific measurable numbers that we will hold ourselves account to. We will know if we're on course to deliver them or not, and can modify path along the way. Underneath each of those objectives, and it comes back again to the discussion we're just having, are in some cases are and will be detailed numbers that add up to that. So how do you get to adding 100,000 healthy life years? Well, it's this bit in cancer early diagnosis, it's this bit in smoking cessation, it's this bit of treating, say, renal disease better. So behind each of these 5 metrics will be detailed plans on how we will achieve them, how we will measure them and monitor them, and then subsequently, so that when we come to renew the plan annually, we'll be able to make modifications. There's not one of those 5 that isn't critically dependent on true system working across Dorset, local authorities, voluntary community sector, the NHS, and indeed businesses and industry, who are all critical parts of this plan. Of course, I'll probably stop and invite questions for going on. Ultimately, these 5 pillars, we believe, are the best way, if we integrate and align people behind them, to deliver on the ICP strategy that ultimately is what the people of Dorset want, and indeed the strategies of the health and wellbeing boards. So I sort of present them to you for discussion and improvement. Of course, a plan's only the very first stage. The next steps, what we really will be doing is a lot of detail work, including a lot of more discussion, a lot more listening, a lot more getting out there to work out how can we do this, and making sure we make the best use of all the resources we have across Dorset, and not just doing things the way that perhaps have been done in the past, but make, I think, even better use of our voluntary sector, making even better use of integrated working. Ultimately, I won't go into detail, but again, for at least 2 of those, if we achieve those objectives or even get close to them, those will be sort of globally leading impacts. Dorset will be a world leader in terms of delivering this. So they are stretching and ambitious, but we believe ultimately they won't just improve the lives of people in Dorset in the next 5 and 10 years, but literally the next generation as well. So I'll stop there. Thank you in advance for challenges and questions.
Thank you for that, Neil. Yeah, any questions or points you wanted to raise, either in the room or online? Sam, did you want to?
Thank you, Chair. Thanks, Neil, and thanks for the introduction. I guess the question I have is about that next phase, isn't it? It's about the next steps in how we unpack what the outcomes mean. And I quite like the way that this has been set up in the bullet points under 7, that we're looking for almost like a 3-way leadership, representation from local authorities, NHS, voluntary community sector. For the Health and Wellbeing Board, though, we've also got to think about place-based partnerships. So it's just keeping an eye on how we understand what the specifics are of the work, and then how and where it's held, so that that's absolutely clear and we're not losing that place-based element, because we're at an early stage, I think, of getting into the work programme that those place-based partnerships will be starting to develop. But what would be tragedy is if we start to have multiple plans that are all generally talking about the same things but approaching them in slightly different directions. We need to work together and corral that resource and be absolutely clear how we can make a difference, and and not duplicate that. That's what sits behind my question. How do we do it?
Oh, I thought I was going to say for a moment there wasn't a question. I think, firstly, I wouldn't claim to have, and you hopefully wouldn't expect to have the single answer, but I think we do it by where we are now. Opening it, having a discussion, being aware of why these things haven't worked, not just in Dorset, not just, but generally in the past. It's very hard to make these things work. And I think that's the highlight to make there is the plan's the plan, but the reality is how we make it work. So I think it's understanding the risks, making sure we're communicating at every stage, making sure we don't repeat, identifying where there's work already going on. So again, this isn't just that none of this is new. A lot of this is the three things really. One, stopping stuff that we shouldn't be doing, and this is sort of, we're looking at that across NHS Dorset, because there's over 600 programmes of work being change and new things going on in NHS Dorset alone, which clearly is so stopping things, I think, across the system that aren't working, aligning and bringing together things that are, again, Phil's highlighted, but so many threads that run through this work, and the risk that in a relatively small place like Dorset we can have multiple things in parallel, which is not the most effective way to do it. And then thirdly, identifying the things that need to start that we're not doing. And then I think to the point is getting that out to place, because it cannot be done centrally, it's getting it out to place. So the relationships and understanding it. So I think identifying stuff that's going to stop, working out to align things better, and then making much better use or full use of place in its entirety. So I hope that didn't just reiterate the question, but I think I'm hearing and emphasising we've got to do that or nothing will happen.
Yes. Thank you. Just wondering how then, just on that, this board gets the right data and insight to know that what's changing and what's being done is having the impact that we're after. And I think that really important point that Sam's just making about how that translates into the place-based approach and is delivered on the ground, but also that we know that we're able to be fleet of foot as much as possible, and our teams can be, to change where they're needed. So how's that?
Yeah. So I think, as you read, sort of the DICE system, the Dorset Information Service, it's really powerful. It addresses the problem of, are we having the impact? How many falls are there being? How many admissions are there being? What is the rate of strokes and fractures? And having I think the key thing is firstly a single view of the truth. So if we can, across probably this board, across other boards, across health, in place budget, here's the single view of the truth. This is the rate of X. This is the impact you're having with real-time data we're all looking at. It will be really, really important, because to answer your point, how do people know the work they're doing is having the impact and when it's not working? So in the planning, we need to make sure we build up that if we do this, we should get this, if we do this, we should get that, but then to monitor those figures and to have a single view of the truth that everyone sees. So this is what's happening to the rate of falls or fractures by different area and by place, and then we can see if the interventions work. So I think a data-driven approach, and it goes back to the point we have to have clear objectives, we have to measure them, otherwise we're just in the dark.
So can that come to this board on a regular basis then, that data, to be able to show what's happening?
I think we have to. That has to be an objective. When you say can it happen now? I don't know is the honest answer. But should it be, and should we make that part of the transformation plan? I absolutely think the answer is we need to make that happen, because if we're transforming things, we need to see what the impacts we're having. And going without data would be like running any other part of your organisation without data. It wouldn't work.
My question is connected in a way, and I almost wanted to jump in and add on the end. But so for the Health and Wellbeing Board, there are some clear expectations and guidelines around what its role is around place and its influence. So I don't see that within the governance arrangements. I see place-based partnerships, which you could argue might be the tag that has a little annotation that says including health wellbeing boards. But it comes back a little bit to the question that Sam asked earlier around how do we know what the person thinks. So data is really important, but it's the qualitative element as well. And I think we miss collectively how we gather that information. So we might ask the question 4 or 5 different times of an individual, was that good or not? And we may record it somewhere, but we're not collating it. We're not asking the question once, what was your experience of the voluntary sector, health and social care, whoever. We need to find a way, as you just described, Neil, of bringing it all together to a single version of the truth that should include that commentary from the individuals about their experience or their family's experience. So I think we have quite a challenge that the data is still fragmented. It's still a bit sporadic. It isn't as comprehensive as we'd like it to be, and it captures parts of the journey, not all of the journey. So, and falls is a really good example, isn't it? So where's our falls prevention agenda, not just our falls intervention after the event, and that those are the kinds of things that we need to get much better at. And but it plays into this plan about the prevention.
Thanks. I don't. David's indicated about it.
Yeah. Can I just share nice? The energy in the room is quite flat, but this is a major sort of piece of work. This is a significant breakthrough. I guess that colleagues have been around, including myself actually, in the NHS anyway, for a long time. This might feel like the usual stuff we usually go for. But actually, the way it's set out and described in the plan is not the same way that we've done it before. This is no longer the thing we're going to aspire to, and it's going to sit over there, and we'll get to it if we can. This is the work that we are going to do, and what we need to do behind the scenes is take out all the stuff that we're currently doing that don't contribute to this, and it's a game changer because we flipped away from being a focus on ill health. So we're going to look after hearts, we're going to look after limbs, we're going to look after disease, to being our focus through NHS, but with our partners, to focusing on how we improve the lives of certain people and certain sections of communities in our across our population. And that's game changing because that means all partners have to come to the table and do this. And it means everybody who works in any part of our communities or any of our organisations has a role to play in making this happen. And I think that deserves a bit more sort of fanfare. I appreciate, this is probably not the right time to do it, but I think it's really, really exciting and groundbreaking, and that creates a whole set of different opportunities and different questions we now have to ask ourselves about how on earth we're going to get and deliver this, and which has come up, of course. The other thing I want to flag is that the 5 pillars are organised in such a way that it's entirely upon us to determine which parts of the work we're going to do that's going to contribute the most to these particular targets. So within BCP, falls has come up because that's a particular challenge within BCP. It's not the same challenge that sits in Dorset. So it's not a one Dorset-wide target. It's something that we can go for. That we know is going to add quality years to people's lives if they are not falling. And the consequence, the benefit, is that they're no longer becoming complex individuals in hospital or needing complex social care packages. But that, again, that's not the goal. The goal is to help with the healthy living and the healthy ways of working. It requires other parts of our system to come together to really make this work. And the place-based partnerships, which you've alluded to a couple of times already, in organising ourselves there, we've got quite a lot of work to do to make sure that local authorities and health and other partners within the footprint of BCP can organise ourselves in order to take on the responsibility for budgets and decision making, which we, the NHS, and hopefully in time local authority, we will delegate to the place-based partnership. So basically handing the responsibility and the opportunity to make decisions against the 5 pillars, but on the basis of the local population needs. And again, that's another exciting development. And within that architecture, the Health and Wellbeing Board will hold the strategic ring. But we'll come, I'm signalling something that's going to come to the next meeting or maybe the one after, but just sort of hold that in your minds that this is still evolving and we've still got plenty of time to influence all of this. And then the other point I wanted to make was around the data, because the data is really, really, really important. And we absolutely recognise that there are milestones and stages that we want to sort of put into the planning, and this is the work that's now going on underneath the publication of this plan to come forward. And in health, our response to that will be to move to an outcomes-based commissioning approach. So at the moment, we buy services based on the number of, I call them turnstile clicks, the number of times people go into hospital, we get a budget for that. In the future, we will be paying contracts based on the outcomes that partners coming together can achieve for the population. Now, that gives us 2 key things really. One is that it actually gets us absolutely into that space of achieving the best outcome for the individual based on their quality of life, which is at the heart of all of these things. And secondly, requires us also to include within the data we use to pay those contracts the patient or the person experience through those services, so how it feels to them. So one of the measures of success of this will be, do you feel your life? I'm not saying this is, I'm not dictating this as a measure, but we will be curious about how well these interventions and these opportunities that we create through this work, how are they contributing to the, to your quality of life? And that will matter to us, and we will organise and change and further improve services if it's not doing that job. So I know that's not the kind of, by next week we're going to have X, Y, and Z in place. And so I fully recognise that, and we're halfway through the book here, aren't we? We don't know what's going to happen next. We've got a sense now where the plot's unfolding. There's loads and loads of work going on to do this, but we're shifting the entire system architecture to make it happen. And right at the heart of it for BCP will be the Health and Wellbeing Board, but this plan will be the one that is the catalyst for that change, and that's why I'm so excited about it, and that's why I wanted to put a bit of that interest back into the room. So apologies if I've got a bit of my hot seat on that one.
Thanks for that. I think it's a report that titles itself "Making Dorset the Healthiest Place to Live" probably does deserve that bit of fanfare. Richard,
yeah. Actually, I mean, I find this really quite interesting, but I'm going to focus on the children bit, as you can well imagine, because it's one line is the 55,000 children becoming overweight by 2040, and I was wondering a bit about the data, but it's not just that, because of course the mental health bit, children's mental health is a big issue, and I'm picking that up a lot from young people, particularly since COVID, and of course children's the way children behave and their experience affects hugely their life expectancy. So the 15 to 19 years, it also starts with the children bit. I was wondering about the numbers, like the 55,000 children preventing. Where do those numbers actually come from, and how can we measure that? Because it's not a definitive number of people that we're going to reduce, is it? Because the overweight problem with children is increasing.
It is.
So are we looking at stopping it increasing? Are we looking at holding it the same? Are we looking at reducing it?
So to answer that question, I'm conscious I feel like a Sunday League footballer sitting next to Pele here, so I'm going to, I could hand it over to Sam, but it's good practice for me to see if I can answer it, because often I don't have Sam sitting here. So what we looked at was as you say, the progression in children who are overweight. The national figures say that by 2040, just under 50% of children will be overweight at age 11. So that's if we do nothing, and that's the national figure, and it's not so it's an accepted figure. So if we carried on doing what we're doing and didn't have effective interventions, half of the children, 11-year-olds, would be overweight in Dorset by 2040. The 55,000 is the delta, the difference between the 50% and 25%. So we're saying by 2040, instead of it going up to 50%, it will be only at 25%. 25% is a fall from where it is now, and would, as I mentioned, be a globally leading way of doing it. We'd all like to have no children would be overweight, but we shoot away from impossible dreams to things that are really challenging now. So the 55,000 children is the difference between if we did nothing and it got to 50% and reducing that percentage of 25,000. The good thing is that you'll probably know is that every 11-year-old gets weighed in a standard way, so it's a standard metric both locally, nationally and internationally. The other thing I want to just pick up, if I may, it wasn't your direct question, but again, underneath that, to do that, it needs a lot of joined up thinking. It goes right back to support for expecting mothers. It goes right back to mental health for mothers and young children. It's all linked in, and you'll see that in all those five, all of them are linked in. So on one level, it looks like, well, you're only worried about children being overweight. What about their mental health? What about exercise? What about their access? What about breastfeeding, for example? All of these things will be underneath that plan if we're going to hit that target. Not to mention, as you say, the illnesses and the long-term impact of being overweight children in terms of the risk of diabetes, the risk of early fractures, the risk of mental health. So there's multiple lines coming back into that. Sam, do you need to improve my assessment of the calculation?
No, I think that was.
Have I listened well?
It was a very very good answer.
That's kind.
But I think it's a good question. It's a good challenge. So when the public health team started thinking about what might sit behind some of the numbers, I'll be honest, at first I wasn't persuaded by going after childhood obesity, mainly because I know that it hasn't been a success in this country so far. It's a really complicated issue. But I do support Neil's stance, which is if we put a number out there, it gives people a target, it gives people something to work for. And actually the really important thing is, as Neil has said, is unpacking what contributes to that and to do that properly. So in my mind, that second stage, which is all part of the next steps in the plan, is understanding what we've got in train at the moment, what might be working, what might not be working. But to even achieve a 5% reduction by age 11 in the National Childhood Measurement Programme in the proportion of children currently who are overweight and obese is very challenging. It's very ambitious, because I don't think anywhere in the country's ever seen a reduction. We're quite fortunate at the moment. The figure's around about 30 to 33%. They do dot around year on year. But to get that back down to 25% and to maintain it in the face of many other areas continuing to go up will require a huge effort. And that's what I think, coming back to David's challenge, is really galvanising about this plan. And I completely agree with the point that's been made earlier. Sometimes when you look at big public sector plans, the statements and the commitments are, no one's going to disagree with them, but they are quite anodyne. This actually has specificity in it, and we've made a commitment to continuing to report on that in public. So I think it's a good thing.
Richard.
Thanks. I'll definitely follow on the ambition, because it is, you know, the moonshot, man on the moon stuff around the level that we're trying to achieve. And I suppose I am interested, a bit like Phil, about the driver diagram behind this. You know, what does each of us individually need to do, and particularly knowing that health services themselves are quite small contributors to these. So, and building on Dave's point, that does mean a radical shift in not just the architecture, but the funding, the effort, the attention. And that's where I think particularly the community sector, the housing sector and others are going to be really critical to this, in many ways more critical than health services. So, so I do think it's quite important to, you know, so no one's going to disagree with these. What's going to be interesting is the commitment to make the shifts that would deliver the drivers to that. The bit I started to pick up language, talk about place, but for me it's communities, which is obviously in the plan, but that's where it's meaningful. Frontline services, communities, interacting, etc. And the bit that I particularly pull out, which I'm really pleased to see in this version, is in terms of the environmental impacts section, and particularly maybe expanding a bit more on those around moving towards a more carbon neutral society, more active transport, and many other changes that we need to see. Again, there's lots of good stuff going on there. Is it enough? And because this plan does go up to 2040, and the news coming in, but you know, pretty much we're looking at a 2.5 degree temperature change. Actually, a lot of these targets are going to be, you know, particularly the healthy aging, will be blown out of the water by the environmental impact. So I do think we need to try and unpick each of those areas where there's lots of passion, and it might be environmental passion, or it might be housing passion, but all of them contributing to that ambition of Dorset being the healthiest place to live. So I absolutely think it's the right thing to do, and look forward to the sessions about how we contribute to this. Thank you.
And I just wonder, on a very practical level, trying to get and make sure that, you know, the people on the ground that are delivering this, how they're really sighted on it. And I hear exactly what you're saying, and you know, love your enthusiasm and all that, David. But for me, to really get this achieved and to see the benefits, for instance, you know, if you look at those 5 pillars, there are groups, there are many groups, there are many work streams, there is much going on. You know, you look at the Home First Accelerator programme, you could put 2 of them 3 of them, if you want to be really kind of looking at them of how they interlink into that. How are we making sure that within that forum, we're going to make sure those 5 key things are at the forefront of all of our minds. It's a bit like our conversation earlier around how do you get health into every policy. You know, the same around in mental health, on the mental health board. How do we make sure that when we're meeting and we're talking about mental health for either children or adults, all age mental health, how do we make sure that that is there, cited, that it's at the forefront of everything that we do? Because unless it tangibly connects and is recognised by people, and I think when, you know, Richard touched about health and, you know, a small part, I don't think any one partner has a small part. And I know that's not what necessarily what was kind of meant, but for me, this is about how do we all collectively feed this into all of the forums that we are, you know, going streets ahead on developing, and how do we make sure that everybody is working to this? Because you said, David, that if it doesn't fit into this plan, we need to question whether we should be putting as much energy, as much funding, as much everything else into that. So we need to be clear then that this is our Bible, almost to a certain degree in this particular area of what we're trying to do and all those works. And that's going to be a real challenge, and that's why I'm saying it's something practical, but it's probably going to be one of the biggest challenge with lots of competing other stuff that's going on.
Yes, I'm conscious, David, you did.
Yeah, I need to hang on for this conversation just to help support and
Thanks. A couple of things for me. One is just thinking about how we're learning from elsewhere. I think everyone's just said, you know, nowhere in the country to do it. I think I was listening to the ex-chief executive Coventry talking about how they, before the pandemic, had reduced childhood obesity, and that was heading in the right direction. I think they're an outlier in that regard, and it's just learning from them and understanding what it was they were doing that was having that impact. The other point I just want to make is the resources one. I think the ambition is absolutely amazing. I think all of our organisations and entities are still focusing our resource into the reactive, the responsive piece, and not in the prevention and intervention. And, you know, at the moment, we're working on a play strategy and struggling to even be able to invest in replacement of play equipment in all of our play sites. And so each of our play sites, at the moment, the approach is the kit doesn't work anymore, it gets removed, you get less pieces of play equipment in each play site. You know, it's the green spaces, it's that whole quality piece that we've got to be able to put the resources into. And at the moment, we're hamstrung in terms of being able to reinvest resources in those areas. So we need to really refocus together on that. And that's going to be some very tough decisions as to where those priorities really are lying when we get down to the detail.
just to add, so I think that's a fair challenge, yes, and we're never going to be able to meet all the things we would love to be able to do. But part of certainly the NHS commitment behind this plan is that we will move as much funding as we can from health services into supporting wherever it needs to go for the best impact for the population. Which might give us the opportunity to consider more fully those opportunities, you know, the kind of, again, won't answer all of them, but that is behind this ambition. So we've got the chance to make a difference.
And I think the point that has been made about the climate change is a really interesting one, because actually, if we invest now in the green infrastructure we need, the insulated homes, the renewable energies, that's not about, almost, I'm saying that's not about preventing the climate change happening, that's about adapting to it. And we've got to adapt now. We've got, this place has got to look different in the next 10 years to be able to adapt to what we're facing in the next 15, 20 years.
Thanks for that. Some really good challenges there, actually. Yeah.
So conscious that of the time, and also I'm getting a lift with David, so I have to go when David goes. And they're great challenges. You've already answered, some of them have been answered by the fact that these challenges, so the communication, the involvement and the engagement of this group, and just seeing that going out and out and out. I think specifically the communication and engagement, absolutely. I mean, in the vision is that this becomes the Dorset way. You know, it's the way we all think every meeting, and I think in our discussion we need to make sure it's clear. Our responsibility is to get it really clear. We've got all sorts of sort of different ways of doing it. Social media. We got commended for the fact that our 5-year plan was the most accessible and readable of any nationally, because we made sure it was for a reading age of 8. That is just the first step, because we need to make sure this is everywhere and accessible and understandable and meaningful. We've already had just one small example. One of Richard's colleagues at UHD came back to me and said, oh, we had a great meeting last week because we based it all around the 5 pillars and rethought what we were doing, and we came up with a whole new lot of opportunities, and that's what we got to get to. So I absolutely accept the challenge, but also see it's a huge opportunity if we can do that. When I said no one else had done it, but we're not going to, the point about learning from others, lots and lots of learning from others, and we need to harness the best both nationally and internationally. When I said we are doing something that people haven't done before, it was putting very specific objectives to our 5-year plan. But as you so rightly point out, there's great work done. Our challenge is to make sure we do it, scale it up, stop doing the things that aren't working, because it's really motivating, should we say, thinking most positive, that the answers are out there to these problems. About resources and prevention, absolutely. And I think there's one first response, which almost risks sounding trite, but I'll bear with it. If we don't do this, the resource problem we have now is going to look like nothing in 5 years' time. So almost like we haven't got an option, we have to find a way. Secondly, it will free up funds and resources. So one example of something that's already happened before the 5-year plan, and you all know, Living Well Dorset are in part of the health villages and the diagnostic centres on the high streets. The diagnostic centre on the high street in Dorchester has been shown already to reduce the demand for elective operations by 10%. And that's sort of DCH's figures in for orthopaedics. And they say it's because we've got a new way of working. 10% of the people who would have been on the operating list are not now on the list, because they've said, actually, we can treat you better with physio, support, a social prescription. So that's just in a matter of 12, 18 months, 10% of people who would have been on an operating list with all the cost and the morbidity that incurs are not on it. Well, if we can scale up things like that, thinking about the prevention, and many of these things do take a long time because they're sort of long term. But again, back to Richard's colleagues, they're saying, hold on, if we do this, we will make difference to the number of strokes and the numbers of falls, and therefore the number of people requiring social care longer term within 12 to 18 months. So absolutely the resource implication. I'm not minimising any of these challenges, but as you can tell, I'm sort of a bit, David and I were sort of bouncing energy off each other, but these challenges make it all the more urgent that we do find solutions to this problem, and we do get it out there, and this is the way we work. So amongst all the other challenges that we all have, but I'm really grateful for the challenges and the improvements and the generally warm responses. But as you say, we all have to make it happen now. So thank you again, Chair, for so much time on the agenda.
Thank you for that. Thank you for bringing some energy into the discussion as well. So thank you for staying with the discussion. I'm just conscious that all the recommendation we have before us is that members note and support the joint forward plan, and sort of happy with the conversation and the next steps in its implementation. Just quickly on the next steps of the implementation, you said about reviewing the plan annually. Will that then sort of come before the Health and Wellbeing boards as well?
I don't know whether it has to, but I hope it will. Sorry.
Chair, we're going to have a discussion about the forward plan later on in the meeting, and I think this is one of those items that we need to pick up. So it's a question for the board to decide how we bring the progress back into it. And I think we can also pick up that issue about indicators and what we measure in relation to progress as well.
And equally, more than happy to come back at any time in between at any time to sort of be challenged, questioned or update with this board. So thank you again.
Thank you.
Okay. Thank you for that. I will formally just ask so all the board are happy to support the joint forward plan and the next steps in its implementation. No, great. Thank you for that. Thank you for staying.
No, thank you.
Just checking around the room, and we are still quorate. I think the quorum, I understand, is 7 of us in the room. So there's 8 still in the room. So that's a sigh of relief. But my first meeting, I wouldn't want to sort of be chairing the first meeting when it became unquorate. Okay. We'll go on to, thanks for that discussion, actually. That was, again, that's very sort of enlightening for me as well, actually. I think it's good to have those couple of papers that we've just looked at they seem to be very key to what we're going to be doing going forward. So, and I take your point, Sam, that we'll be discussing the forward plan. So we need to reflect on what we've just listened to. Agenda item 9 is the preparation for CQC assurance. So Betty, that's for you to present. If you
Yeah, thank you. This won't take very long. I do have a presentation, but I don't think we need to put it up unless if the board want it up. I think I can just talk through. You do have the paper that was submitted, so I'll just talk through some of the highlights of the paper, if that's okay. So some of you may have already heard this, as some of you will have been involved in peer reviews and other national discussions around CQC assurance. So just for some context, the Health and Care Act 2022 created a new duty for CQC, the Care Quality Commission, to review local authorities' performance. So that's where the duty has come. The CQC have not formally inspected adult social care local authority areas for over a decade. They have continued to inspect areas of care providers, care provisions within local authorities, but not in the way that they are doing now as we go forward. So it was just to give you some context around that. And if you have the paper in front of you, or if you've looked at the paper, it's around looking at adult care in line with their Care Act duties. That's how adult care work. They work to their Care Act duties. And although they'll be coming into the council and the adult social care areas within the council, it is a wider system, piece of work as well. So what we've been doing, or what we know in regards to CQC, we know the CQC are currently in with 5 councils throughout the country, and those 5 councils are going through the inspection process. It's being referred to as an insurance process. So they are going through this with inspectors, with CQC. This is really driven nationally from government or from ministers to really get a sense of how it feels and what the quality and what the outcomes for individuals are that are going through this area that's going to be looked at. So within adult social care and the wider partner kind of processes for individuals. So we know that there's currently those 5 areas. We know that from October onwards, as it stands now, I would say things are constantly changing. So there may be some changes to this. We know that CQC's intention is to come into around 40 councils from September through, well, from October really, to the next quarter of that, and then so on, so that over a 2-year period they get to see all council areas. So they're going to be coming in, they're going to be really looking at what we talked about earlier in the connections to some of the other papers that we've heard around the individual's journey. They really want to understand what is it like for that individual. They want to hear people's stories. They want to know the people with lived experience, and carers have been really involved in this process. They want to really hear from practitioners, from partners, from community groups around how it really feels for them, and how their experience, and is it delivering against what they believe their needs and their outcomes should be, and are we doing that in partnership with them? So what we've been doing in preparation for that within BCP Adult Social Care is we had a bespoke safeguarding review take place. It took place in February. They came in and looked at how we were delivering safeguarding and how that felt for individuals and how practitioners were doing that. So we had that done. We had a report on that. We put some actions against that. Overall, that was telling us that people felt safe and that practitioners were delivering against the areas that they were assessing people against and that were being highlighted to them as part of that assessment. I would stress that this was only on a small scale. It wasn't a massive piece of work, and with CQC assurance that will be much, much bigger and have a lot more resource that will come into BCP adult social care, you know, whenever our time comes for that. So we had that in February. We also had a local government association peer review, and most councils are putting themselves or have had a peer review undertaken by the LGA. So the local government association had a team of people that came into us. It was over, they were with us for 3 days, 3.5 days. But prior to that, that was early June, the 6th of June, that started. Prior to that, we had sent them lots of information. They had read all our national published information. And we had produced a self-assessment document, which was around 50 pages, which CQC will use that same format, and that outlined where we thought we were, where we thought we are now, and where we need to get to, and what we felt we were doing okay or doing well in, and the areas that we felt that we need to deliver better on and we need more resources on. So that self-assessment was one of the fundamental documents, and we asked the peer review leads to really test, did we have that right? Did we know ourselves, and did we know ourselves well? So they really scrutinised that for us as well. So, and they based that against the 4 things the CQC will look at. You know, CQC are going to be looking at what's working for people, what are we providing, so what support are we providing to people, insurance, safety, and leadership and governance. So we know they're going to be the kind of 4 key areas. We haven't yet had the local government association report. We were expecting a couple of weeks ago, but due to their pressures of everybody wanting a peer review before CQC assurance lands with them, they're a bit behind. But I am expecting it either tomorrow or early next week, and that is a published document that will be published. There were lots of things in that around partners, you know, health partners. You know, our health partners were part of this process, as was our voluntary community groups. So I guess for us it's about making sure that we take the learning for everything, getting ourselves as prepared as we can be for CQC to come in anytime from October to do an assurance process within BCP Council on adult social care. And just a little bit around 4 themes: working with people, providing support, insurance, safety and leadership. The kind of evidence that they'll ask for is around people's experience. Feedback from partners is critical. Feedback from staff and leaders, observations, processes and outcomes and impact. They are really changing the kind of old way of doing inspections or assurance process. It is very much around the person's experience and their stories and their journeys, and what was the outcome for them and how did it feel for them. So the purpose of bringing the report that you will have seen and identifying that today, just for the Health and Wellbeing Board, is that this will be something that will be coming. It will be coming fairly soon. It is fundamentally about wellbeing, and it is fundamentally about people within the BCP area, and it will be a joint thing with all of our partners and how we deliver on that. The outcomes will be published, as I've said, and if it's determined that the local authority is unable to manage or has been unable to manage what is deemed to be expected and not deliver their statutory duties, then the Department of Health and Social Care will have some statutory interventions that they will put in place to support at that stage. You know, let's hope we don't get to that position, but that will be the kind of worst case scenario, even though it would be a supportive intervention. it would take away some of that control from the local authorities and the local system. So it's really to kind of make you aware, and it is to maybe be asked to bring something back as well in the recommendations. We don't have a defined time scale yet. We're advised that CQC will give us probably a month's notice. But during that month, they'll be asking for information. They'll be looking at data, and they'll be doing all their exploratory work before they come in to us. We have heard, and again, this could change, that it is very likely the CQC will come into 2 or 3 councils within the Southwest from September, October time. So we could be one of those 3 areas. And, you know, they're very focused on discharge. They're very focused on prevention, how we work with partners, all of that stuff. So there isn't any of us within the health and social care system that won't have a role to play within this. Happy to take any questions, Chair. I think that's probably a quick summary of the overall position and report.
Okay. Any questions, Richard? I think.
Thanks for the update and the heads up. Yeah, CQC. So we're going for our well-led at the moment. You know, as Dorset, it is a massive amount of work. So I appreciate that. It's going to take a lot of time. And you're right. It's a chance both to shine and really promote the things you're doing well, but also how well do you know the things you're not good at? That's the, as you say, the classic test. I'm just very conscious. Last time I sat in this room, I think next to Jess, there was the challenge about what could partners have done before the children's inspection, and I'm just wondering if there's any learning from that we could take. So as a system, we're doing all we can to support, and it's got to be a fair and reflective assessment. But we know there are things we can do that might be able to help. So it'd be useful perhaps to explore maybe outside the meeting what practical things we can do that will help, because we know that a lower, would it be one word, would it be one of the 4 words summary?
There will be a rating.
Yeah, a rating. So we know that has a massive implication on recruitment and retention as well as public confidence. So it's in all our interests for this to go successfully. I think the bit about CQC increasingly taking risk-based approaches. So those first 3 won't be a random 3. They'll probably be ones that, for whatever reason, are on the radar. So our system-based assessments, and I have no idea where BCP stands in the region, but that will give some indication of probably in which order we'll be seen. So
if I may, Chair, come back on some of what Richard said. So Richard, on a practical level around partners, I would like to thank partners for their participation in the LGA peer review. All of our partners were part of that. We had discussions. I'd gone to the ICP board, presented, and they are really aware and fully signed up to supporting with us. I think one of the things that could is going to be a challenge for us is our data. How we have one single version of the truth as a system. If we're looking at it as a system, and some of what we talked about earlier around how we get really, really good data that we're all sharing and how we're telling that narrative collectively. And I know that's being picked up through the Home First acceleration group, because I was on a meeting earlier about that where we were talking about that. So I think that's going to be a real practical but key focus for CQC when they're looking at us as a system, as well as looking at us as a council. The data is going to be really, really critical within that. And I think the offer of help is very much there. We will take full advantage of that. And I think you're right in the intensity and the amount of work that this takes is incredible. And I guess in discussions that I've had within BCP and within, with partners throughout Dorset, is that given our system being under the spotlight nationally, given many other factors, it could be very probable that we will be one of those sites that will get a visit fairly early on, but we don't know that. So that's just an intuitive, quick calculation based on some of the factors that we think they may use to identify, that the minister might decide to identify and say these would be good areas to look at first.
Okay, thanks for that, Sam. You indicated.
I think my question was partly covered by Richard's. It's that important of also looking at the system assessment, isn't it? Because I think NHS Dorset are going to be a pilot for the CQC integrated care system assessments. There's lots of CQC activity going on. It's important we've got a clear story between us as separate organisations when we're being assessed, but also as a system.
And I think also, just on that, Dorset Council will be on the radar for inspections too, as all councils will be. So it is really important that we're not saying different things about our system working, because we're all part of the same system. So that's a really critical point that hopefully we will make sure that we triangulate.
Any other comments or questions or thoughts? Thanks for that summary report, actually. But yeah, I think it is important that we're all sort of aware that this is going on. I suppose my question is, I took part in the LJ peer review in the second week post, so it was a little bit daunting. But actually, I think I've said before, it's probably the best thing for me actually that we're waiting for the report, but we'll have a report there that sort of spells everything out, so it'd make my life much easier to sort of be able to sort of have that in writing and sort of work to make sure that we are sort of as prepared as we can be to get the sort of best outcome we can hope for. So just in terms of what do we want to see as the Health and Wellbeing Board, in terms of, you sort of suggested about sort of feedback to the Health and Wellbeing Board, sort of post-visit sort of thing. Yeah. Is that, will that be useful? Is that something that we're going to?
I think it would. I was going to ask about, I mean, you're waiting for the initial findings of the peer challenge as well. And I take it that's not been published yet, has it? But
no.
Just getting a feel for what the peer challenge found would be useful even before the formal assessment, I think. So whether that could come back as a short note. Yeah.
To share that around with partners so that they've got a heads up of where we're at.
Was there anything initially from the sort of end of the session feedback they could share?
So we did have an initial kind of feedback session with them, but again, I mean, the report will be a lot more detailed and we'll go into that, but just on one or two of the things, two of the positive things that really stuck in my head from them was that they felt our staff were really resilient. All of the staff that they met, that was partner staff as well, and I thought, well, we kind of would have expected that to some degree. They felt that staff were really proud of the work that they were doing, and they also they felt that staff were really committed and that the leadership felt good. So that was the kind of positive stuff. The kind of areas that we know, they felt that we were carrying significant, well, not significant, but we were carrying or managing risk around backlog. And backlog, by backlog I mean those waiting for assessments, those waiting for review. And they know that the pandemic would have had a big part to play in that. They also, cited some things like we're a new administration, and that might be a challenge and a positive. Our budgetary challenges as well. So they were just some of the kind of the key things, and just demonstrating much more tangibly in our self-assessment, maybe one or two areas, particularly around co-production. We were probably doing a lot more on co-production than what we'd initially sold or highlighted within our self-assessment. But we hope that they're going to go into much more detail, and data was one of that. Data was a key area as well, and how we need to really get the data and get the collective support from the wider council and wider partners on the data that we need. But the detail, the devil will be in the detail of the report.
I think one of the positives that I picked up from at the end of the review was also about the working with housing and the closeness between sort of housing and the social works and social care. As they said, it was unusual. They don't sort of come across that in other authorities.
There's been a lot of work done around things like extra care housing, supported housing review. So there's been, and it's been really close working about how do we tackle the wider accommodation problems rather than relying on residential care, that traditional option for people who require a certain level of care.
They really like things like shared lives, which the only way I can describe that is almost like, you know, fostering for adults, where instead of people going into residential care, they would go and live with a shared lives, you know, individual or partner who would support those individuals. And others are starting to do that, but we've been doing that for a very long time. So there was some really good positives and there was some really good learning. But as I say, this is not good. That was a good brief to do before. But CQC are going to be a different element in
themselves. Quite so friendly.
You know, just paraphrasing what Richard had said. You know, we know they're going to really scrutinise.
Okay.
Thank you.
Thanks for that and those comments. Thanks for that report, Betty. It's a useful summary. So yeah, if there's any other sort of comments or questions you want to take your points out actually about being able to see the sort of the LGA report, I'm looking forward to that as well. So great, thank you. Okay, we'll move on to the next agenda. We've obviously covered item 10, the Better Care Fund already. Item 11, pharmaceutical needs assessment supplementary statement. So Sam, this is for you to.
Yeah, I'm going to talk to this. Thank you, Chair. I hope I'm not going to take too much energy out of the room on this item. It's perhaps not the most riveting thing that we do, but just to make the board aware that it's a statutory responsibility of the Health and Wellbeing Board to oversee the preparation and the publication of something called a pharmaceutical needs assessment. In simple language, this is a piece of work that looks at the spread and location of pharmacies, the operating hours and the types of services that they provide. And it's basically a piece of work that's then used to assess whether there are any gaps or significant gaps in access to pharmacy services. And it's also used by NHS England when they're making decisions about the commissioning of new pharmacies. So if you wanted to open a new pharmacy business or make changes to your current business, you have to do that in conjunction with the commissioner, which in this case last year was NHS England, and the pharmaceutical needs assessment is effectively a bit of a backstop to say that the local system has had a check about access to pharmacy services and that we're assured that there are no significant changes or gaps in provision that are opening up. So this paper is basically reporting back to the Health and Wellbeing Board that there have been some changes to pharmacy services. There's been an assessment done as to whether those changes are significant. If they were significant, then the legislation requires us to redo the pharmaceutical needs assessment. But in this case, the panel felt that they weren't significant changes. And so the paper is presenting a summary of those changes, but it's asking the board to recommend a delegated authority to me to publish this as a supplementary statement to the pharmacy needs assessment. We've also provided some detail in one of the appendices about exactly what these changes are. They're largely because Lloyds as a chain has made a decision to take out some of the pharmacies that were located in branches of Sainsbury's supermarket. So those are the main changes that are covered by the supplementary statement. And we're also reporting back on the response that was drafted on behalf of the Health and Wellbeing Board back to NHS England in relation to an application to consolidate 2 sites. Again, we did an assessment. We use a 20-minute drive time as the sort of criterion to judge whether there's alternative provision, and we decided that there wasn't a risk of change or a limit to access to pharmacy services. So that's the paper, and I'll just go through the recommendations in detail. Bear with me a second. So what we're asking the board to do is to approve the publication of the supplementary statement and delegate authority to me effectively to keep publishing these statements as long as the panel are assured that there aren't significant changes, in which case we'd have to go back to the board with an entirely new pharmacy needs assessment. There you go.
Okay, thanks for that.
Happy to take questions.
Yeah, any points or questions? All sounds good to me. I did have a couple of little questions. I mean, Boots are closing stores at the moment. Does that include pharmacies as far as you know? I need to sort of check up the latest news items.
Yeah, I think one of the issues we're very aware of, which we put into the paper, is the reason for not redoing the entire pharmacy needs assessment is that there are further changes that are likely to come down the track, and that will be because of legislation that's going to look at the opening hours, and particularly the rules around 100-hour pharmacies. So we're going to keep the issue under review. Going back to that criterion, the panel are always mindful of, is there alternative provision? So in an area like BCP Council, quite often you do have other pharmacies that are accessible within that 20-minute drive time. It's actually more of an issue in the Dorset Council area, where you've got sometimes one very, very small pharmacy serving a village, and it might be more than 20 minutes if that pharmacy closes. So sometimes that does present access issues. But we'll keep it under review, and obviously the board will probably be receiving further supplementary reports.
Okay. So the recommendation on that item is just for the board to approve publication of supplementary statement, delegate authority to the Director of Public Health to publish such further statements as required, and to note the response to the NHS England on a consolidation request. So we're all happy to nodding. Yeah, good. Thank you for that. Agenda item 12, review of membership of the board to consider the future membership of the board. Yeah,
Chair, I'm happy to open up discussion on this. So if you look back to the minutes of the previous meeting, you'll notice that we still have, to some extent, a membership that reflects the previous system. So we've got a couple of GP reps who were members of the clinical commissioning group, because it was a GP membership organisation. That's now been replaced by NHS Dorset. So the start of the conversation today is really how we review the membership to make sure that the board's appropriate for the business in front of it. And I guess the question I would ask is, as we start to think about what the place-based partnership might start to deliver, there might be an opportunity for us to co-opt or invite other people onto the Health and Wellbeing Board, depending on what business would be in front of the board as we start to refresh the plans and the strategies, not least in the light of the NHS joint forward plan. So I think one of the questions I had, and it's a shame we don't have NHS Dorset colleagues here, because one of the questions was, how do we get clinical representation that can bring that voice through from their understanding of what's going on in their localities, not necessarily as corporate members of NHS Dorset, because their structures changed. So the GPs are now part of a new organisation called the GP Alliance. And I think it's a question that we'd probably need to put by Patricia Miller, potentially, as to what might be appropriate membership. I'm happy to kind of open up to other questions and comments about who else might need to sit on the board.
Okay.
I would support what Sam said around how do we get that more local health input, the on the ground input, if you want to call it that. I think we do need to refresh. If we look at the list of the membership, it's both out of date and some of the titles have changed. So we probably need to just reflect the structure of the council more in here, and just some of the names may have changed. And is it the right representation? So I think it's just perhaps officers could take it away and just do a refresh, and then and as you said, it's because David's left, and Neil, we might need to just touch base with David and Patricia afterwards, just have a conversation about how we might do that, and perhaps update the board post-contract, post-meeting, rather than wait till the next meeting.
Does that sound okay? So the action would be for you to catch up with Patricia, maybe, to make sure that sort of NHS Dorset or the NHS, the health side representation is sort of fits with the structures and delivers what we need the Health and Wellbeing Board to deliver. Okay. Yeah, and I think you're right. Actually, the sort of update report following those discussions, rather than sort of come to the next meeting and say, oh, we want to change this and we'll have to approve this. So, is everybody content with that? Is that going to work? Okay, thank you for that. Item 13 then, the forward plan development session. So Sam, did you want to introduce, present the item?
Yeah, thank you very much. So I think the first thing to say, Chair, is that again, going back to the previous meeting, we agreed an action following a paper that came to the board, which was looking at developing the Health and Wellbeing Board in the light of the ICP strategy, some of the new responsibilities that come to Health and Wellbeing Boards. Obviously, we've since had change of administration. We've got a brand new chair of the Health and Wellbeing Board, so it hasn't felt right to push ahead with the development session until we've kind of found our feet and got into a new pattern of working. So I think the discussion today is really just continuing to, first of all, acknowledge that we haven't progressed that development session yet, but we do definitely need to get on with it. And that development session will be looking at some of the implications, not just of the ICP strategy, but obviously the plan that we've heard today, and some of those discussions we started to have about how do we hold the ring on making a difference in our place, and the place being BCP Council and the Health and Wellbeing Board holding the ring on that. There are some other responsibilities that were picked up in a refresh of the guidance back in December 2022. So I'm happy to work with other officers to develop a draft forward plan. Some of that will be items that we know have to come forward onto the Health and Wellbeing Board over the year. So I think that we're going to be asked every year for an assessment of how well NHS Dorset is doing on leading the system. We also have to give an opinion on the delivery against the NHS Joint Forward Plan, and I think we're also supposed to look at their capital plans as well. So we'll dig all of that detail out and we'll start to put that into a draft document for consideration by the Health and Wellbeing Board. I think the other question I'd put to the board today is to whether it would be helpful to give members more of a flavour of what some of the work might look like under the Joint Forward Plan. So I can think of a couple of items that have been, perhaps the board was cited on last year, Poverty Truth Commission being one. When the Commission was just about to launch, they came to the Health and Wellbeing Board to tell us about what the Commission was all about. Jess and I have sat on the Commission for a year. It's just had its celebration event, and now the embedding work is starting to happen. There's quite a close link between that work and some of the issues that we're picking up in the ICP strategy. So one item that I'd like to suggest would be hearing from some of the members of those task and finish groups with particular relevance to some of the work of the Health and Wellbeing Board. And I think unpacking some of those big outcomes that were in the NHS Joint Forward Plan and what do they mean, it might be useful to hear about some of the work that I know is being planned around cardiovascular disease prevention. So I think it's going to be a big public campaign around knowing your numbers, which is about finding cases of high blood pressure at an early basis. So again, I think we can put some suggestions forward for how we populate that. I'm happy to bring that back to the next, working with fellow officers.
Okay, thanks for that. Yeah, the Poverty Truth Commission's interesting when you brought up there as well, because I know it's sort of regular cabinet meetings. It's come up recently because of the stage they've got to actually as well. So to me, that sounds sort of chimes. Any other comments on the forward plan or questions?
Chair, it's all right. There's one item there about the future of hospitals, so happy to bring to the next meeting perhaps an update on the changes, particularly so we're in University Hospital Dorset. There's obviously quite a lot of changes going on, and thank you for those who were there at the theatre opening yesterday. But also conscious colleagues in mental health, there's significant changes in all of the hospital sector in mental health in the conurbation. So I haven't got the date for the next one, but I'm sure we could present if that is okay for the agenda.
I think that sounds good to me, actually, because I know probably each of us probably see different bits of it as things are going along. You know, I came along Tuesday and saw the sort of the bit of Poole Hospital, but I think being kept up to date with the whole programme and where things are at and what's happening next is going to be important for us all to sort of be, understand. Okay, thanks for that. Any other comments on what else is sort of listed there as future items? Obviously, the discussions that we've had today, sort of earlier discussions about the joint forward plan and the Better Care Fund as well. We talked about having sort of report backs on those. So those were actions, I guess, we picked up in those earlier agenda items. So we want to make sure that those fit within our sort of draft forward plan. We schedule those in as it requires.
Chair, the other item that's linked with this is this concept of a development session, and I don't know if the board have a feel for how you would like to do that. Sometimes we've done joint sessions with Dorset Council Health and Wellbeing Board. There's pros and cons, I think, to that approach. One of the benefits is it saves everyone time, and if we're talking about system things, then it's largely the same for both health and wellbeing boards, particularly how we relate to the integrated care system. I guess the downside is you don't have as much of a focus on some of the business that might be more closely reflecting the challenges in our place. So it's something for people to think about, but I know everyone's busy. So if people have got ideas or strong feelings about how to do that, then myself and Sarah Longdon are sort of helping to schedule some of this, including how we support the development of the integrated care partnership. So probably need to get something in the diary in the autumn at some point, I'd suggest.
Yeah, because I think these development sessions coming up for the ICB and the ICP.
We've got one on the 28th of July, which is the ICP.
Yes, the ICP.
We've got one on the first week of August on the ICB. Yeah, August, I think.
Yeah, I know they'll seem to pop up in the diary in the next couple of weeks. So, so it would seem timely. I guess it's realistically it's got to be after the summer holidays, as it says. Yes, we'll have to have discussions about how best to approach that and initially get dates in the diary, and then our diaries are going to be busy, particularly in September and October. You know, one or two things might be coming up around that time. Okay. Just looking at future items to be allocated to meeting dates here, whether there's any which you picked up about the changes to hospitals and role of hospitals. Those others that we've got there to be confirmed. Place-based partnership report from EWC. David's name is against that, so do we need to speak to him?
Yeah, it's a live discussion at the moment. I think there's a couple of places where that report needs to be considered, but it also needs to come to the Health and Wellbeing Board for discussion, not necessarily for decision, but definitely for discussion.
Yeah. It does fit into that the role of the Health and Wellbeing Board in the governance area. So it is. I guess it's important for this. It is important for the board to think about that, and perhaps that it might be in alignment with the development session there, Sam, about what does that report tell us, and then what do we need to work on.
Eliminating food insecurity, access to food partnership, as it says, identified as a theme within the health and wellbeing strategy. So is it something that needs to come to board imminently, or is it?
The team, well, it's ongoing work, and it's Cat McMillan and the team, and they'd be very happy to bring it when we'd like to see it. There'll be an update on progress with what we've been doing and what we're looking at doing going forward. And aligned to corporate strategy thinking.
I wonder just if because children's services, there's also some, particularly during the summer, about access to food. And so I wonder if we can children's enjoying that up as a part around that access to food Friday.
I think Cat McMillan and
Was
the
that
team already
linked
join
into
up,
it?
yeah.
Yeah, so it would fall part of that.
Right, okay, so we just need to think about scheduling that.
Yeah, no, it's really about timing when the board, look a bit on the board plan.
Okay, got a few other bits there. Vibrant Communities Partnership Board, report from the co-chair to the board on the work of the partnership board. Becoming more and more familiar with numerous boards, but I've not come across the Vibrant Communities Partnership Board as yet, so I need to understand a bit more about that. So not sure where that request to come from, or it's been there a long time. I don't know, some of these things do sit on board plans for substantial. Okay, so we'll question that one about how. Okay, BCP local plan. We've got that as a request from the chair for Laura right now. I know as councillors we've had a big session just the other day about where the BCP local plan was.
I think the idea of this one was to think about what, a health perspective, what's emerging through the local plan, what's the direction of travel, and actually building awareness really of this board in order for us to think strategically about how that fits to the wider work we're doing, the wider strategies that are developing, and how it's a tool to meet some of that need.
Right. Okay. Yeah, just trying to think from the other night with the presentation I had from Laura and Steve Dring about what stage they're at with the local plan, because we're certainly talking to ward members quite extensively about the timetable and where we are and what their sort of thoughts are. So it needs to fit in with so it's not just so much an update for us, but actually something where we can probably feed into a discussion about what's going to be in the local plan. We don't want to sort of have them come along and then say, oh well, this is what we put in the local plan. Tough, we've sort of that's gone into it. So yeah, we need to probably speak to them to make sure that it's sort of our timings aligned with the timings for the local plan. Okay. Any other on those items? And there's a couple of the actions that we picked up earlier to schedule in. We need to do some work to, like I say now, back into the new sort of municipal year. Actually, it's timely now to sort of actually start to thrash some of that, scheduling different meetings. So, Emma, did you want to?
Yeah, I just wondered whether or not it might be pertinent, listening to a lot of the conversation, whether there's needed an update around the voluntary and community sector assembly and the work that's been going on to co-develop and co-design that within the system.
There's a few nodding heads here, so yeah, we will add that into the list. We'll sort of try and come up with some plans for the next couple of meetings. But yeah, definitely quite a few nods. Thank you. Okay, any other input or comments for that? Conscious, but we've got 2 minutes left before the scheduled end time of the meeting, so 120 seconds if you want to chuck anything else into the board plan. No? Okay. Thank you for that. Thank you for your time. I'm glad we made it on time. So that I will close the meeting. Thank you.
Thank you.
2 minutes to spare.